everybody. Welcome back to another episode of Between Sessions with Berries. I'm really excited to have our guest today. He has a wealth of knowledge. We actually had to try to pare down what to talk about because he has so much expertise. Dr. Ron Albucher is here with us today. So glad to have you here. I just want to read your bio, just a little brief abbreviated bio here. Dr. Ron Albucher is the former Director of Counseling and Psychological Services, a clinical associate professor of psychiatry in the Stanford Medical School's Department of Psychiatry. He is currently a clinical assistant professor of psychiatry at UCSF Medical School and in private practice in San Francisco. Amazing to have you here. Thank you so much for being here. I'd love for you just to say a little something about yourself and what's going on in your life right now, and then we could dive into some of these amazing topics that we're going to talk about.
Yeah. Well, I think you got my major bio correct. I had been at Stanford for about 15 years and then decided to do more private practice. So I expanded my private practice in San Francisco and then also did teaching and supervision at UCSF. And I really enjoy all of those aspects. I do a mixture of psychopharmacology consults, and also I do a particular type of psychotherapy called intensive short-term dynamic psychotherapy, and we can, certainly talk more about that later.
I'm looking forward to talking about that. That's one modality I'm not that familiar with, so I'm excited to share it with the listeners for sure. But
Right.
what I would love to dive into is the biological piece of when we have clients that come into our office. When does a clinician decide, I think I need to refer out to psychiatry, I think maybe this client needs medication? I was wondering if you could just walk us through that process. Like, what is the thought process and what should a clinician know to get their client that extra level of help if they've got a need for biological interventions? Yeah.
Yeah, and you and I also spoke briefly about kind of the issue of burnout, which is a real issue, I think, in our field. And so I want to also kind of loop that in here to answer your question, which, oftentimes our work can be somewhat lonely. We spend a lot of our time just one-on-one. If we're struggling with something, right, oftentimes we do it alone. Occasionally we'll grab a colleague to run it by them. But one of the things I think, for instance, a psychiatric consultation could be useful for is, if you have a client where it's just not going that well in the therapy, either they've made some progress but they seem to plateau, or they're just not responding to treatment in the same way most of the patients you would see would respond. I think it's a good idea, even if medicines are not on the table, to at least have kind of a second opinion or an outside opinion. I do this also for myself when I feel stuck or unsure. And again, happy to talk more about that. But I find it very useful. And, because it doesn't feel good to us to feel stuck for so long. We like helping people. And if they're not getting better, it's a negative experience.
So frustrating sometimes.
Right.
Yeah. And talking about burnout, it's like, gosh, I could think of many clients that I've just put, what's that saying? Like, if you're putting more work in than the client is, like, you might be working a little too hard. But really,
right.
just you don't want to give up on your clients either, I think, a lot of us,
Right. Yeah. And, when we talk about the ISTDP type of therapy, one of the main contributions I feel it's made to how I practice is around this issue of resistance and alliance with our patients. So a lot of our patients have some type of attachment trauma growing up. And so it makes sense from their perspective to both try to trust us but not trust us at the same time. And so they're going to want to get better and work with us. And then there's a part of them that's going to resist that and pull away. Mm-hmm. And it's that resistance part that can get into trouble for them making forward progress. And if we don't address that resistance kind of in a direct way, then I think that's when therapy can stall.
Absolutely.
And so we can go into that maybe a little bit more.
I'd love to talk about that. Like, what are good interventions for that, like, direct talking about resistance, like, because you almost, especially if it's trauma-based, right? You don't want to push them too hard. There's that dance you do, sort of an intuitive dance,
That's
I think,
right.
as therapists, where it's like, feels like it's a little too much. I don't want to go too far, but then you're right. I mean, they're looking to us to guide them a little bit on this process too. So like
That's right.
what are some interventions that we could use in those situations? That'd be so helpful.
Yeah, so I find it's helpful even, having been doing this work for 30 years or so, to go back to basics with people, because oftentimes if there's a problem, I find I may have rushed through kind of the foundation of the connection, thinking we were on the same page, and in reality we're not. And so I always find it's helpful to go back to the basics. Why are they coming to me, right? So first of all, is there even what we would think of as an internal problem that they want help with, rather than an external issue, right? It's my partner or I have a bad job or something. Those things may be true, but you're here with me in the session. We can only work on you and your contribution to it, or your, right? Not looking at, something. So getting that internal focus down, right, is really important. And I've been in situations where I've not paid attention to that early on, and it's become a problem later, because then you're talking about the problematic partner or the
Yeah, you're
problematic
joining with them.
job.
It's like, yeah, it's pretty awful.
Exactly. Yeah, right,
Yeah.
right. And then it kind of stall out.
Yeah.
And so more so than looking at, okay, well, what are you bringing to this situation, right? Why are you in this relationship? Why are you in this job? Let's be curious about that. What are the pluses and minuses? And what do you want to do about that? So applying pressure to them to get really clear with you about what are their goals in therapy. Are they even goals you can help them with? Because if they say, I want my partner to stop doing blah, 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 and you're not doing couples therapy, then, no, the answer is, yeah, I can't help with that, right? And so let's find something I can help you with. So I think getting all of that clear is so important. And that's what I find when I make mistakes, and of course I still do, with my patients. That's what I find. It's a particular area of importance that I've rushed through and not paid enough attention. So we're not even on the same page on what we're doing together in the session, right?
Yeah, that makes so much sense. So you're starting
So
to feel the
getting
resistance.
clear goals and then there's a resistance because you're not even focused on what they want help with, right? So there's a mismatch, right? And we also chatted a bit about this before we went on the air, but about, therapy, it's okay to have mismatches. In fact, it's unavoidable. And it's not about the mismatch as much as the repair. So catching it, talking to them about it, showing how you can repair, taking ownership. Gee, I screwed up. I really was focused on this and you wanted help with that. Let's get back on track together, right? And so those kinds of things actually strengthen the therapeutic alliance and then help get therapy unstuck at that point. So
amazing. That is so great. So we're recognizing the resistance, then we're pulling it back in by focusing back on the internal issues that are really brought them to us to begin with. So they get back on track, and then let's say we're back on track. We're aligned again. We're working on this internal issue. We're trying to figure out how to fix it together, that sort of thing. When as a clinician am I like, okay, I think there needs to be medical intervention here? Like, what am I seeing in the client? What is the client presenting with that would lead me to then say, I think we need to do a psych consult to see if some medication would help?
Yeah, no, that's a great question. And I don't have a completely pat answer to that because I'm still trying to figure it out. I thought I would get better over 30 years at predicting this person's going to respond well to medicine and therefore they should be referred, and this one's not. And I still get that wrong. Like, I am amazed by, oh, I thought this person was going to get a really robust response and, they got a minimal response or something. And then this person that I could have sworn this was all psychological and, the therapy was on track and everything, they had an amazing response to, So I mean, one of the guidelines I try to use is the intensity of their symptoms and whether that's helping the therapy or getting in the way. So if, let's say, their anxiety is too strong, right? And so some of the resistance that we were chatting about earlier may come from a very healthy place at trying to protect them from overwhelming anxiety as you're trying to help explore deeper things with them. And so in those kinds of cases, if self-regulation is just not enough to bring down the anxiety level, then medicine may have some role. It may have a function there to, again, accelerate the therapy. Or, depression is so severe that their motivation level is really off, and it's affecting even coming to therapy or participating and being present in the therapy, this kind of depleted depression.
Oh gosh,
right?
Those are the hardest, in my opinion. Those are the hardest clients.
Right.
Oh my gosh. Yes.
Because you don't have a foothold to begin with in terms of the mutual motivation, and you can kind of cheerlead for them to get them going, but if they're so depleted they can't join you, right, that might be another situation where medicine can be really helpful, I found. So
now, what do you recommend for a clinician that's not a prescriber? Like when I was seeing a lot of clients, I had a psychiatrist that I always just referred to. I loved him for 20 years. Do you recommend clinicians trying to find psychiatrists that they really connect with to be able to do referrals back and forth?
Exactly.
Okay.
Totally. Yeah. That you read my mind on that it's again about relationships. And so it's now the relationship between therapist and psychiatrist. You want somebody who you can openly discuss a case, you can share information back and forth with the patient's permission.
Nice.
Somebody who values your work also, right? And is willing to grapple with some of these hard issues, and not automatically jump to prescribing, but think about it as part of the whole picture and what might make sense for, that particular person. So I think the quality of that relationship is really important. And then also, what is that psychiatrist good and not so good with, right?
I was just thinking that.
We all have our strengths, yeah.
Yes, because there's so many options these days, like ketamine-assisted therapy. There's TMS, that transcranial magnetic stimulation. And I see lots of modalities coming out now that I'm just super curious about. But obviously, I would guess not every psychiatrist can specialize in that stuff or even have knowledge about some of those other modalities. So I just wonder,
That's right.
how do you even, as a clinician, figure out the right referral source for those type of interventions?
Yeah, so, as you're getting to know your psychiatrist, right, you do get a sense of that. I mean, I don't prescribe ketamine or do transcranial magnetic stimulation, but I actually do refer, and I have referral people that I'm comfortable with that do those modalities. And so I think finding a psychiatrist, for instance, that, it has that as part of their repertoire, if not directly, certainly they have referral pathways that they'll share with you and help the patient get into treatment or get into an assessment for that. Right, because I've had some really very amazing results with, there's a protocol of transcranial magnetic stimulation that I've found has helped almost everybody I've sent. And again, some of these people I was like, I'm not sure this is the best referral, but let's give it a shot since the medicines haven't worked. And sure enough, they've gotten benefit out of it. And had I hesitated too much, I would have deprived them of that treatment. And so I think, being willing to grapple with that and know, okay, this clinic is good for that, but not so good for this other thing. And,
Yeah, kind of learning as you go, who are the best people.
Exactly.
Absolutely.
Exactly.
And you made a good point, because I've heard that too about the TMS and the ketamine, even that, especially if you're insurance based, that they've got to fail medications, a number of medications before insurance will even pick up these other modalities, is my understanding. I'm not sure if that's the same in California, but yeah.
Yeah, it is. Usually they'll want people to fail 2 good medication trials prior to recommending it, in part because those other treatments are more expensive, and so they're trying to contain costs that way. But yeah.
Yeah.
But clinically, I think that does also make more sense. We're just beginning to learn about these other modalities compared to, antidepressants have been around since the 50s in one form or another. And so, we have a lot longer track record with those.
So you're in a unique position too, right? Because you're a prescriber and doing psychotherapy. So you kind of, I guess you see that trajectory all the time. Let's try the traditional stuff. Let's focus back on the internal. That's not working. Let's maybe try some medications. And then maybe let's refer you out to this other option.
Absolutely.
Is that sort of how your process goes? Okay.
Exactly, right. Yeah, and again, people that I thought, oh, they're going to respond well to therapy. They have a clear loss that is linked to depression and anxiety, that it kind of all made sense, and we did the work, and I thought I helped them grieve and work through and all their mixed feelings towards the lost person. And they didn't get a lot better. And then it's like, okay, well, it's possible I didn't do the best job, so we shouldn't totally rule out therapy as an option, but do we want to start now thinking about these other treatments? And, I think being open-minded, we're working with the most complex part of the human body, and we're just beginning to understand some of it, and so
oh my gosh,
I think we have to have a lot of self-compassion for our own limitations in doing this kind of work. So
now, as a prescriber, I would love if you could maybe just share about, from your perspective, if a clinician calls you and wants to refer somebody to you, do you like to collaborate? Do you like to have the information from the clinician? Because I think, especially newer clinicians, I think it's really intimidating to call up a psychiatrist and say, hey, I think this person might be bipolar. This is why. Could you evaluate them? I think that could be intimidating. So I just wonder if you have any tips for clinicians, on how to do that process.
Sure, yeah. Well, and again, I think you're going to learn about the person of the psychiatrist through those kinds of interactions, right? So do they respect your opinion? Mm-hmm. Even if you've not been trained that way, you've been around people like this and begin to get a sense of, oh, these people look like bipolar patients, and indeed they respond to mood stabilizers, right? So, you begin to get an appreciation after you've done this for a while. And so I always try to be mindful of my respect for my colleagues, because if you're coming to me with a patient, you've spent a lot more time with them than I will as the medication consultant. So not only valuing what you're telling me in the beginning, but then the ongoing treatment. You're going to have regular contact. I'm going to see them monthly or something, and so for a briefer time. So, making sure that there is that mutual respect is so important.
That's amazing. So even evaluating that yourself as a clinician with who you're referring to, it's somebody that's going to be open to feedback and collaboration.
Exactly, because how are they treating you as the referring person?
Yes.
It's going to bear on how they're treating your patient, right? I mean, if there's kind of a disrespect of any kind, as opposed to a curiosity and a saying, oh yeah, could be bipolar, I'm happy to see them and try to figure it out with you. And,
yes.
That more collaborative approach, right? I really think, one of the other things I've appreciated over now, 30 plus years of doing it is that one of the reasons I think I get better outcomes with the exact same medications is because of all of these other factors that I try to attend to. The quality of connection with the referring therapist, the quality of the connection with the patient, the willingness to admit I sometimes mess up and let's correct that rather than just trying to do the same thing.
Yeah.
All of those things, I think, I know that's how I would want to be treated by my doctor. And so to me always seemed common sense, but it's not always so common.
No, absolutely not. I've had run-ins over the years. It's like, please listen to me. This is not normal. There's something going on here,
Exactly.
And you get mixed.
Same for me,
yeah,
too.
I'm sure.
Yeah, as a psychiatrist, referring to maybe a more specialized program, and sometimes you don't get the response you're looking for. So
Yes.
or
Oh
the
my
courtesy
gosh.
you're looking for.
Yeah, it's like, or we can't admit or we can't take them on because of this, or that. There's also other restrictions that can be frustrating when we're trying to coordinate care, I think.
Exactly.
So tell us about your modality that you use mostly, because you were telling me a little bit about it before we hit record. I just thought it was super interesting because I hadn't really heard of it before. So I'd love to just educate the audience on these other modalities that are available out there.
Yeah. So I've been training for about a little more than 10 years now in a type of therapy called intensive short-term dynamic psychotherapy, and it has the acronym ISTDP. And you'd mentioned you hadn't heard of it. I'm not surprised. It's not very well known, even though I've attended so many different trainings on CBT, DBT, and so on. This was the first training I went to that consistently showed videotape. And to me, there's an honesty in the videotape where you're seeing the mistakes the therapist is doing as well as the good stuff that they're doing. And you do get to see what the impact is in real time on the patient. And so that's one of the things I like about this field is that we all, as much as we can, we try to videotape our work. When we present at a conference, we'll show the video. And so, there's some more direct experience for people learning it rather than me telling you, here's what I think I did, and here was the response. You actually get to see it. You see the patient's facial expressions, their body language. And these are things that you get trained to monitor in this type of therapy, by the way. So it's very much a somatic type of therapy in addition to emotion-focused
Oh,
type
amazing.
of therapy. So you learn things that I never learned in my training or even afterwards around monitoring anxiety in the body, for instance, which can show up in different systems. It can show up in voluntary muscle, so fidgeting, wringing of the hands, sighing. And so I had to train myself, and this is where the video comes in handy, is going back and watching, oh, there was a sigh right after I asked this question. The sigh indicates a blip in anxiety level, and that is usually linked to mixed feelings coming up as a result of the question you asked. And so it gives you a chance then to do a deeper dive with the patient. You begin to draw their attention to it. You ask them, how did you just feel when I said that you're ignoring blah, blah, blah in your life, or, you're not advocating for yourself as much or something? Because they're going to have a mixed feeling about that, right?
Yes.
They're thankful that you're seeing it and pointing it out, and they're pissed off at you for seeing it and pointing it out, because none of us like
I
our
don't want to talk
defenses
about that.
touched.
That's why I
Exactly.
sighed.
We're all built this way. And so I think helping them to then feel those mixed feelings, right? Of appreciation, love for the fact that you're spending time with them and trying to help them. And at the same time, you're kind of pointing things out that they don't want messed with and they prefer, like you said, not to deal with.
Yes.
And so that's going to make them angry and frustrated and, and then teaching them to be in touch with those feelings as they come up. And that's a large part of what this type of therapy does. The idea, if I can reduce it to a more simple concept, is that we all have attachment trauma growing up of different severities. And that results in mixed feelings towards people we care about, usually our parents and family. And sometimes then those mixed feelings we don't want to deal with, and so we push them down, or we ignore them, or we turn them back on ourselves, right? Instead of being angry with you, my alcoholic parent, I become angry with myself for making you mad at me in the first place, right? And so then I start a pattern of self-attacking and self-abuse, as opposed to having my anger towards you, And so it's those types of attachment disruptions that can lead to later on in life things like symptoms of anxiety, depression, etc. Full-blown personality disorders if they're really entrenched and rigid defenses used. Even symptoms like psychosis if the anxiety gets too high and the trauma was severe enough. So in those cases, you take a different approach to help strengthen them to face these feelings that they've been avoided. So that's kind of the big picture, helping people get back in touch in a physical way with their feelings, dealing with the fact that we all have mixed feelings towards important people in our lives, and coming to terms with that because it's not so pretty, right?
Right.
We want to just think we love and that's it, and
more
it's
complicated.
Always mixture, yeah.
Now, is it a brief therapy process in the acronym? Like, is it something that is supposed to have quick results based on this modality? Short term was in the acronym. Okay.
Yeah. Yes, and when I first started doing it, I'm like, why is it not like short term? Well, what Habib Davanloo, who came up with this type of therapy, what he meant by that was really comparing it to a psychoanalytic treatment.
Oh,
right?
gotcha.
Yeah. So in general, I would say I treat most of my patients within a year to 2 year kind of a treatment. And so sometimes you get lucky or the issues aren't as deep and you can do it in a handful of sessions. But honestly, that's rare. And I think the people that practice, and when you go to conferences and compare notes, most people are in the 1 to 2 year range.
Yeah, I think so too. I did a poll actually recently, and it was like average of 24 months, I think, is what some people said in one of my Facebook groups. Yeah. So it was like, okay, people are seeing clients a lot longer than these insurance companies would lead you to believe that you're supposed to do it in like 8 sessions or something like that. So
right.
Totally.
And you can start helping in 8 sessions, but the idea that where are you leaving them at that point, right?
Yeah.
Will they go back at the next stressor that they face, or do you have some kind of solid ground under their feet? And so that's the problem, and people don't get this way overnight also, right? They're coming to us even in their 30s or so, they've had 3 or 4 decades of practicing things a different way. And
absolutely. Yeah.
So,
so
it takes
interesting.
some time.
So is this a certification people get, or is this just a modality you can train in generally?
More the second. There's no kind of official certification, but I'm actually this year and next president of our therapy organization, which is the abbreviation there is the IEDTA. And we host a biennial meeting alternating between Europe and North America in its location. Next year we'll be in Dubrovnik, Croatia.
Nice.
And so if you want to come and join us,
I might.
it should be quite nice. Yeah. So
that's amazing.
In fact, I'm going there next week to
fun.
check out the hotels and the conference center and so on to make sure that the pictures say that
scouting trip.
Scouting it out, right? Exactly.
I love that. That's so interesting. I definitely want to read more about that modality. And, it brings up kind of another thing we were talking about before we hit record, and that's the role that AI is starting to play in our practices and the work that we do. We both use berries and love berries. But just hearing you talk, imagine an AI kind of watching in the background that's picking up on these things that you're already trained in, as we were touching on before. But the sigh, or these symptoms that you're trained in this modality to pick up on a lot. I mean, wouldn't that just be incredible? I mean,
amazing.
As an assistant.
It would be, that's right. So you could imagine either after you're done with the session or even potentially during that you're getting some kind of feedback from the AI that's going to be so much more attuned, right?
Yes.
I mean, because all of us know, during a session we go in and out of focus with our patients, and sometimes we're reflecting and thinking, sometimes we get distracted, sometimes, right?
Yeah.
So then we come back and the AI doesn't have that problem, it just stays focused. And so it can be looking at, what's the eye contact like? Wow. Overall, how much anxiety is showing up in the body, right? And it can give you that feedback to kind of reconfirm what you are picking up on yourself, or maybe help you sharpen those skills, right? And I just think that it opens up so much amazing
Gosh.
possibilities for training.
Could you imagine the what do they wear for biofeedback? You know, like picking up on like body temperature, sweaty hands, pulse
Yeah, all the
increasing.
haptic
Like, could you
stuff.
imagine
Yeah, right.
being hooked up to an AI that's like giving feedback to the clinician in real time? I mean,
Right,
that would be
right.
incredible, I think.
Yes,
Yeah.
absolutely. And, you know, even without all of that, there still is so much AI can pick up on, like eye connection, micro expressions in the
Yes.
facial musculature that, again, we can train ourselves to do, and it's important, but AI is just going to
Yeah. But it's like,
know how to do it out of the
how
box.
can you
And
be
so,
attuned to a micro expression, a twitch here when you're looking here? You know, it's like you can't
exactly.
pay attention to everything, you know? So,
Exactly. At
gosh,
100%, whereas the AI has no problem doing that. So, yeah.
yeah.
I see it as just, you know, a lot of pluses. And yes, of course, there are risks with it as well. But I think the potential for pluses, especially in training us to be better therapists and you know,
Yes.
which is all we all want to do that. So getting back to the burnout issue, right?
Yes.
If we feel we're progressing throughout our career, which isn't always the case, right?
Absolutely. The more burned
then
out
it's
you
a
get, the
different
less
experience.
effective you are. I
Exactly.
mean, of course, right? Because you can't put all
Exactly.
that energy into it. Yeah.
Right, and you're starting to pull away from your field, and yeah, you know, there's a lot of, I think, exciting things coming down the pike that will really revolutionize how we train people. You know, because even, you know, I was impressed when I learned this that there's almost no correlation between supervision and better outcomes. And so, kind of the thing that we hang our hat on in our field of, yes, we're going to train you how to do this better, you know, there's almost no correlation there. And so, you know, when you look at the degree of outcomes, and so then it's like, oh gosh, we're doing this, but it's really not that effective. How do we do
Wow.
better? You
That's
know?
amazing. Yeah, I never thought
Yeah,
of it like
right?
that. Yeah, because there's so
Yeah,
many factors. Like, what if your supervisor isn't very good? You know,
exactly.
or, you know, like
Exactly.
what if you're
Or
not really
harmful
sharing what's
even, yeah.
really going on in the session, you know, with your supervisor? I mean, there's so many
which
factors.
which we're going to do either because, you know, we may have shame that,
Yep.
oh, I should have picked up on that, or we may not have seen it,
Hmm.
right? We don't know what to look for, so therefore how can we convey what we missed to our,
Yes.
and that's where again I think video is essential. Like when I supervise people, I really try to push for videotape. So because there's so much that they won't see that I can pick up on and
Yeah.
then begin to teach them to look for. And so,
Yeah. And
and they
imagine,
may have presented a totally different
yeah,
picture of the
exactly.
patient
It's
than
like
I
that is not
have.
what happened at all.
Yeah, right,
And
exactly.
imagine running that through AI first to get like some feedback and then being able to present that to your clinician based
Right,
on your observation and
exactly.
the AI's observation. Like, how amazing would that be?
Amazing. Yeah,
Gosh,
right.
kind of scary maybe
Right.
for the clinician being analyzed by AI and a supervisor, but
Right, and showing videotape, right? I mean, for me,
yeah.
that was one of the hardest things to do because here I was 3/4 of the way into my career, you know, and now I have to show people and then even
Oh,
get critiqued on
oh,
it because I'm actually not doing it the way it's optimal, and
yeah.
so that can really hurt. And
Oh
so
my
you
gosh.
have to kind of gird yourself and find a group that's supportive to work with, right? That's
Right.
not going to be punitive about it or shaming in any way. And so
Absolutely.
it's so
Gosh.
important, yeah.
Oh my gosh. Yeah, so many factors go into that.
Because it's a hard field, what we try to
I
do.
know.
So, I mean, you know, no, until you get into it, you don't realize how hard it really is.
It's
But
so true. Yeah, I'm thinking about
yeah,
this podcast, and I host two other podcasts. I've never once gone back and listened to a single one of them because it's painful to go back and like
exactly.
watch yourself. You know,
Absolutely.
like we're our biggest critics
Absolutely.
too. You know,
Exactly, right. And saying, oh God, I can't believe I said that, or, you
what
know,
was I
right,
thinking?
you know,
Yeah.
yeah, why did I make that face, you know, right. So, yeah, so absolutely. The only thing I tell people is, look, you're in good company because
Totally.
all of the rest of us do the same thing. So,
Yeah.
you know,
Oh, I love that. I bet you're an amazing
yeah.
supervisor too.
Oh, thank you. Thank you.
Oh
Yeah.
my gosh. Well, thank you so much for taking the time today to share all of this. I think it's going to be so helpful
My
to the
pleasure.
listeners. And if somebody wants to reach out to you to learn about your conferences or your modality, how
Absolutely.
would they find you? How would they contact you?
Yeah, my email, which is Dr. Albucher, so it's DR for doctor, and then altogether, Albucher, my last name, ALBUCHER @gmail.com.
Amazing.
And happy to talk with anybody and share more information about anything we've chatted about.
Amazing, yeah. And that conference sounds fantastic.
The conference is really amazing. Like I had mentioned earlier, I've gone to a bunch of different trainings and different types of therapy, and I always learn something. This was the first time I kind of got blown away.
Wow.
Because I actually saw not only what the person was doing, and it was tracking with what they said they were going to be trying to do,
Yes.
but then also the impact on the patient and how profound the impact was. And I'm like, wow, I want to do that. That was impressive.
Wow.
And so, if you go to YouTube and check ISTDP, there's quite a bit out there already on there. Obviously not patient material, but
Right.
a lot about teaching and so on. And so I think you can get a much broader experience than what I'm giving here. And then obviously you can connect with our organization, the IEDTA, or other groups that teach this, and check it out, see if it's a good fit for yourself. So
yeah, the only other two modalities was EMDR, watching that in live person in training, that blew my mind, and hypnotherapy.
Yes.
Both of those, I was just like, oh my gosh, this is like
Okay.
instantaneous.
Yes.
This is so amazing. So I'm really excited
Yes.
to check this out and watch it even on YouTube to see what it's all about. Thank you so much for taking the time.